We're going to be talking about TAVR. First, I thought I should show you cases that I've done in the past, but we've done a couple of nice cases recently, so perhaps we can discuss them. So we have a 78-year-old female who has critical aortic stenosis. Her mean gradient is 78. Her kidneys are fine. She is a non-smoker, but she's extremely petite. She's like 38 or 39 kilograms. Naeem, very briefly, what should be our approach for a patient who is symptomatic and has severe AS?
Thank you, Dr. Hakeem, for giving me this opportunity to come and sit over here and talk about this in this session. In case of a patient who is having aortic stenosis, remember that when we are going to talk about the guideline-directed medical therapy, remember in patients who are with aortic stenosis, the patients who have been included in the trials are those patients who are more than 65 years of age, number one. Number two, the patients, most of these patients are tricuspid if we talk about the trials. And in our setup, majority of our patients, like more than 50% of patients are bicuspid. So the important things that we should consider in such patients is, first of all, you have to look at the anatomy of the patient, the aortic root, annulus size, the size of the sinus of Valsalva, STD junction, the height of the coronary vessels from the annulus, the amount of the calcium that's present, and the angle of the annulus itself. And if you come down to the bifurcation of the aorta, then we should look for the size of the external iliacs. We should know about the size of the access site vessels, whether these are the femorals, or we are having our plan from the axillary, or in some specialized centers, definitely they go for the transcaval and transcarotid. So the ejection fraction of the patient, renal function, all these are the important factors that you should know before the planning to go for the TAVI in such patients.
Okay, so you already decided we should do TAVI in this patient.
As I mentioned, a patient who is more than 65 years of age, so we should know the fidelity of these patients. If the patient is having a high risk for surgery, like STS score is very high, the patient is very flail, and as you mentioned, the BMI is very low. So these are the patients who are definitely at very high risk for the surgery.
Okay, very good. So if I just told you patient's very symptomatic, the EF is completely normal. This is for Khalid Naseeb sahib. I have a certain fondness for Khalid. It is purely platonic. If let's just say the EF was about 25, EF was 55% and the mean gradient was about 30. But she's very symptomatic. How do we reconcile that? Do we say she has moderate AS, or do you want to do something else? She's very, very, very symptomatic. Her lungs are completely fine. Hemoglobin is okay. But she is extremely, extremely symptomatic. And the S2 is diminished on exam, if you happen to listen to the chest.
Thank you. Give the chance of as an expert. First, I want to take the complete history, the symptomatic due to...
Okay, I'm the patient. Take a complete history.
Okay.
Okay, you're going to make this very painful. Okay, let's cut to the chase. Okay.
About the history, about the other condition during patient symptomatic due to, you told about the not anemic, but chronic angina disease is also present with the patient. First, we have to take the angina symptom of this patient.
That's very important. That's a very, very, very important point, because understand in the elderly, you would not get classic angina. She's 78. She very well could have multi-vessel disease or left main disease. And on top of that, she could have pure moderate AS. That would change everything.
Everything.
Okay. All right.
First, about the coronary artery disease, suppose do the CT angio and coronary artery disease is not present, that's too much severe, mild to moderate disease, then other cause, I check the patient other things. Other things means के other comorbids, kidney and other things not. Otherwise, I want to जो already more symptomatic तो I no go for the any stress set. If patient symptomatic and अगर do chance to do the exercise test and decrease the blood pressure and other things, so definitely we go to intervention.
I think what Dr. Abdul Hakeem is trying to make a point is that she's 78 years old. She's asymptomatic. Her ejection fraction is normal, but despite of normal ejection fraction, her mean gradient is 30, right? So there's something called low flow, low gradient severe aortic stenosis, despite normal
But
ejection
I think you
fraction.
mentioned mean gradient is 78 in this patient.
No,
I said,
scenario.
okay. Just for the sake of,
So for the sake of discussion, and it's very common to see in an elderly petite lady with a small LV cavity, you might see that. And what's that? So that's why it's called low flow, normal gradient, severe aortic stenosis, right? So that's what you see in a petite lady, elderly lady with a small LV cavity. And sometimes you may be thrown off by seeing a 30 millimeter gradient instead of more than 40. But in those patients, you have to look at the other criteria. You have to look at the aortic valve area.
That's very important.
Right? That's something, and you have to look at the symptoms. So definitely, even despite 30 millimeter of gradient, and it does not meet that criteria, you can also look at the dimensionless index, right, in those patients. That might give you some idea. So that's the point I guess you were trying to make. Normal ejection fraction, low gradient, elderly lady.
so, now our understanding of AS has evolved. We have three phenotypes. One is a classic high gradient, high flow, preserved EF, or low EF, but with high gradient, high flow. That is called the D1 variant of AS. D2 is somebody has LV dysfunction, either ischemic, non-ischemic, and that is low flow, low gradient. Okay, so in those cases, to really distinguish it from pseudo, you could either do dobutamine or you do a calcium score. If it's more than 1200 for females and more than 2000 for men, it is severe AS. And then third is the D3 variant, which is these small ladies with very small ventricles, absolutely no cavity. Because they don't have a cavity, they can't generate enough gradient. Okay, so that's a paradoxical low flow, low gradient. And in this case, in addition to the things that Dr. Khan mentioned, calcium score is also very important. So if you have a lady whose calcium score is, say, 2000, given that clinical scenario, you would. But understand that the outcomes of TAVR are most questionable in the T3 variant, because we really don't know if they're going to do well, if the degree of LV hypertrophy regresses, if their diastolic dysfunction is going to regress by putting a prosthesis. Okay, so coming back to our patient, yeah, she indeed does have that. And Jehangir, why don't you walk us through what we're looking at here, what we're seeing right here, and what we're seeing at the sinus level.
So before selecting the patient, we have to do the CT scan to see the perimetry, and you can see the cusp, and you have to see the peripherals like access site. If you are planning for retrograde access, just like a femoral, so you have to see the size of the vessel and the external iliac and all. It should be more than 5 millimeter, and you have to see the calcification, and along with as Dr. Mengal already discussed, we have to measure the perimetry, cusp area, the height of the coronaries that are fitting for our device. It should be more than 10 millimeter, and we have to check the angle along this. So these are the CT finding before going for the any TAVR intervention, and you have to rule out the other pathology. If patient having on the echo, we have to rule out that there is no any LV thrombus, or patient survival life expectancy should be more than 1 year. These are the ingredients if we are planning for the TAVI in these patients.
Okay, and what do you think about the valve here? What kind of a valve is this?
So in this, the perimetry is 612, and you can see the cusp. In this, there the bicuspid valve seen on the second side is the severe calcification RAF is there. So we can see the type of valve, in which type of bicuspid valve is there with the help of CT.
Okay, so what kind of a bicuspid is this? What kind of bicuspid valves are there?
It's a type 0.
What kind of valve should we put in this patient?
So, although for bicuspid valve, there is no any data available regarding. Most of the robust trial was done on the tricuspid valve, and this is depend upon the calculation. After doing calculation, you can fix the valve.
No. So you can also look at her peripheral anatomy, right? Or peripheral anatomy seems very nasty.
Yeah.
We have the external iliac, that's 3.6, 3.8, average is 3.8.
So it's
and on the left side too, we are approaching an average of 4.
Along with some calcification, so the peripheral, they are not fit for the retrograde approach in this patient. So in this patient, we have to see the other access sites, so that's like a subclavian. I want to see the other access site for my approach.
Okay. All right, Dr. Khan, why don't you tell us what your approach would be looking at the anatomy here?
Well, it's it will be a little challenging. Again, a very petite lady, and the vessel sizes are kind of at the borderline. We should have at least 5 millimeter of vessel, and it's touching that boundary. We can attempt that. Talking about alternative accesses, again, just to kind of give you 1 minute like spiel on it, is that 95% of the cases can be performed through transfemoral, and if we kind of tend to go to other sites, for example, subclavian sites or axillary sites, they are a little ergonomically challenging, more radiation. And then when we go to the carotids, in some centers, it is their number one choice, alternative choice after transfemoral. Some reports of a little higher rates of stroke. Axillary access has about 5 to 6% risk of stroke.
And we are having an option of antegrade approach, just go through the venous access. The first
so that's called. So then the transapical is more of like historic nature. Now it's an open surgery, very high risk. The direct aortic approach, then the transcaval approach. The transcaval approach, again, in some centers, for example, Emory, that is the number one alternative site. It's just like transfemoral, but you are going through the vein. But there are some cost issues associated with it. So in this case, I know it's kind of touching that borderline. I don't know what the other auxiliary sites are, but I think if we are in safe hands, we can definitely attempt transfemoral in this patient. But we have to be very careful.
Careful and versatile.
It's around that borderline arteries, 5 millimeter, but I think we can attempt that.
What do you think, Khalid? Would you go transfemoral or... Okay, just to answer your question, her subclavians are 3 and 3.5.
And that's out of the question.
Okay.
How about, transcaval? What is your experience with that?
I've never done a transcaval in my life. Zero experience.
We have only seen the femoral diameter here, but the annular angulation, aorto-annular angulation is not given.
Yeah, there's a lot of things. I just wanted it to be a crisp discussion. So angulation was fair. Okay.
I think the transcarotid is another option, but then the only valve you can use is the Edward Sapien, which we don't have here, right?
Not yet.
And it could be other better choice as long as we know the carotid status. But that is, you have to have surgeon in the board. That is in like open surgery, and but it's safer. It's direct access. I think if I have to choose alternative access, it has to be transfemoral first, followed by transcarotid, and then transcaval. Those are the three choices.
Okay, so I'll tell you, in our practice in my previous life, our go-to approach was subclavian. But we didn't do it fully percutaneous. Had the surgeon do an arteriotomy, put a graft, and we did it through that.
6% risk of stroke.
No, but I'll tell you, in well over 24 cases, 0 strokes. But it wasn't fully transcutaneous. You see what I'm saying? The surgeon did the exposed the artery, did an arteriotomy, put a temporary graft through which we put the sheath in, did the procedure, and then came out. So I think the only thing that appears forgiving about this anatomy is that there is no calcium. Dr. Khan gave you a great talk on peripheral arterial disease, but I'll tell you it's calcium that causes a huge problem. So in this case, we went back and forth a couple of times. So again, what did we decide about the valve size? What size would you put, Naeem?
Okay.
No, give me a valve size. No discussion. What valve size?
I think 23 will be more than
23 will be more than enough. Jehangir? 23. Khalid?
23 or 26. Let's do the balloon first and see how it goes.
Okay, so all right, so this brings us to the second point. Is someone keeping track of time?
Yes.
Okay. Should we pre-balloon?
Ideally, in every case, definitely we should go for pre-ballooning, especially when the patient is having bicuspid valve. There is calcium. I think better to go with pre-ballooning.
What do you think, Jehangir?
Yeah, you have to do. But in this case, we can't see the severe calcification.
No, there is severe calcification. Yeah. I gave you a frame because you see, I've given you a frame where there is a lot of calcium in this. Just take my word.
So 18 mm balloon will be enough minimum diameter.
What size balloon would you use, Naeem?
I'll go with 18 mm balloon. There's minimum to that of annulus.
Okay, so that's one thing, but also understand by far the most important determinant of sizing your balloon for pre-valve BAV is your sinotubular junction diameter. Okay, so if you've got a constricted STJ and your sinuses are huge, and your LVOT and annulus say are an average of 24, but say your STJ is really constricted, it's about 16, you're not going to take a 24 balloon. Okay, you're going to cause massive. So you go by the. Okay, so I disagree with the first part that you should always pre-balloon. In balloon expandable valves, we almost never pre-balloon. Because understand, in my first talk today, I told you that the risk of stroke is constant at 2 to 3%. In the best centers, the highest volume centers, it is 2 to 3%, which means that 3 out of every 100 patients will get a stroke. So the fewer the passes across the aortic valve, the lower the risk of stroke. So, but when you have balloon expandable platforms, you almost always want to pre-balloon, because if you do that, in about 2/3 of the cases, you would obviate the need for post-dilation. And in self-expanding platforms, you don't want to post-dilate because you can embolize the valve. Okay? All right. So in this case, we decided to go, okay, so Sohail, you said you are very gutsy, you would go transfemoral. How would your approach be different? Walk us through how you would approach this case, just for our satellite colleagues and our other colleagues. Okay. How would you use your standard 2 pre-closes or 1 pre-close, or you want pre-close?
We have to, depending on, again, the center at the Cleveland Clinic, they do all the sheets in one groin, right? But normal, like standard is that we prep both the groins. On one groin, what we do is that we get venous access, put our temporary pacer in just in case. And also through that, if we have to cross our pigtail into it, we get that access, put a 6 French sheet. The groin that we decide where we see there's not a lot of angulation or calcium, and that's the site we should choose for our bigger sheet. And I think looking at it in this case, again on the right side, it's around 0.4. So most likely, left side, most likely you must have chosen the right common femoral for your large access sheet. Is that correct?
No, we went with the left because
okay.
the right, because I was most concerned about the external iliac on this side. See, it's about, you probably can't see it from your angle,
Okay, all right.
but the average is about 3.8, very, very
Okay.
borderline.
I think you would ask about the ProGlide. We can just go with the one ProGlide because the vessel size is small.
What do you think? Would you use?
I think one ProGlide. I mean, that's what I've seen. It worked just fine. I mean, instead of using two like per-close devices.
So
Again, once you choose the site, you can go in and put a per-close device. We'll just go with one device, because if you put two, I've also seen patient where you completely shut down the vessel after you're done with your TAVR, and then we'll take it from there.
Okay, so you guys understand the point that Dr. Khan just said about closing the artery with per-close. I've had it happen at least 4 times in my career, and it's the nastiest thing. Sometimes, even when the vascular surgeon goes in, he can't find the lumen, because the way that happens is typically when you take a bite, you want to have anterior stick under ultrasound guidance. You want the foot plate to be absolutely parallel to the artery, and you take one bite. Sometimes one foot plate is against the posterior wall. So you take one bite of the anterior wall and one off the posterior wall. And you can't tell right away because you've not tightened the knot. Now, at the conclusion of the procedure, when you pull the sheath out, you tighten the knots. So you've literally taken a bite from the posterior wall and you close the artery. So in this case, now, there used to be a concept of the protection wire. In this case, we've abandoned that. We almost never use it. So in this case, we put a protection wire, a V18 control, in the left popliteal, just in case if anything untoward was to happen. Yeah, you have to have covered stents available. Yes, that's important. So again, I think it was fairly straightforward. Again, this is, to me, the most important step, okay? Regardless of how experienced you are, I will tell you, I know people who've done, Jeff Popma has probably done more evolutes than anyone else in the world. He's probably done a couple of thousands, okay? And he says to this day, this is the part that he's most scared of, is how to release the valve. Because understand, it's a self-expanding platform. It continues to expand. And we had a very close shave in one of our first cases here, where we almost popped the valve out. So you have to be very careful. The most important thing is to get the nose cone in the center, and you can see you've really brought the wire back inside the nose cone, so it's almost central. Again, this is less than ideal because the assembly of the valve is against the greater curvature. Ideally, you want everything right to be centered. Okay, so I think this patient did really well. Had trace PVL on follow-up echo 4 weeks later. She had no PVL, and her symptoms absolutely went away.
It's just one of the, you can add to that, when you have this of a small LV cavity with so much of gradient, do you think she will be at the high risk of the LV suicide? Is that the typical case you will see?
Sohail Khan is a magician. This patient did have a suicide ventricle. Who saw this patient in post-op? They called me and said, oh, the patient is extremely hypotensive. So obviously, if you've just done a TAVR, the patient's in the recovery area, and they call you that the patient is very hypotensive, what are the first 3 things you've got to rule out? 1, 2, 3. So you want to make sure there's no vascular issue, okay? So groins are fine, you send a stat hemoglobin, right? Yeah, so very first thing you want to do is what? Put a probe on the chest, make sure and more importantly, make sure the valve is still in place, the valve is not embolized, okay? That's the problem with these self-expanding platforms. So, and at the end of the procedure, when they said, oh, the mean gradient is about 4 or 5, And now there we were getting a gradient of close to 40, 45. So what the hell happened? Okay, the patient got a suicide ventricle. So we gave her, started her on a phenylephrine drip, gave her a fluid bolus, and also gave her albumin. With albumin, you expand the volume, and once you get blood pressure higher up, you can give them 2.5 of IV metoprolol, and then another 2.5, another 2.5. So I think that's a very, very good point. And then within an hour or so, she was fine. I think we kept her for a day or so. And so this is another patient. This is a fairly recent case, 74-year-old, class 4 heart failure, severe systolic dysfunction. Okay, this has refused to play, but take my word for it, the EF was about 20-25%. Okay. But again, I'm telling you the EF is 20-25%. But what's most striking about this? No, what? Exactly. The size of the LV. EF could be 20-25%, but the LV is not dilated, which is why the patient is able to mount a gradient of 103. An EF of 20%, a mean gradient of 103. What is this patient's left ventricular pressure? It's over 250, or maybe more than 300, because the max gradient is 163. So if you imagine the blood pressure is 120, although this patient was hypotensive and on pressors, right? So let's just say blood pressure is 90 or 100, the LV pressure is close to 270. So the fact that the LV is not dilated gives you hope that this patient is going to turn around. Okay, so there's a long story of how whatever happened, but the patient just kept going downhill, and we had to do this rather urgently on a weekend. So this patient also has a nasty bicuspid valve. Okay, and you can see there's a lot of calcium here. And now this, somebody had asked me earlier if I would use embolic protection. This is one case, just looking at the density of calcium, I would definitely go for embolic protection, because you never know, one chunk of that calcium can break loose. So this was really a borderline between 34 and 29. But understand that in bicuspid, your anchor is not the annulus. Your anchor is the calcified raphe, or the plane, which is going to hold the valve. It doesn't matter. It doesn't matter how big or small your annulus is. If you are to deploy 100-0, you just rely on your annulus. So typically we use intercommissal distance, which is about 4 millimeters above the annulus. And so in this individual, about 30. So 29 would have been a good fit, okay? So you can see his LV is really down, okay? LV is really down. Obviously, in this case, you don't want to rapid pace. Typically, you want to do, and you can appreciate the amount of calcium that's there. You don't want to rapid pace because the patient get really, and for patients like this, patients who have LV dysfunction, always a good idea, Again, I wish we've got almost 100 patients now, but I never wrote this. Starting the patient on dobutamine a day before, low dose, about 5 mics per kick per minute, tends to have relatively good outcomes. Patients, and whether it has good outcomes or not, but their LV recovers right away. So we did a BAV, I forget if it was 20 or 22, and then we took 29.
Balloon size, first dilate the balloon size.
20, I think it was 20 by 60 or 20, I forget, but it was one of the two. All right, so Naeem, why don't you just tell us briefly on your thoughts on whether we should deploy in the coplanar view or the cusp overlap view, and just tell our audience what the difference is.
Thank you. Especially if there's a patient who is with a tricuspid valve, the cusp overlap view before this coming to this cusp overlap view, we used to go on the coplanar view. But as the data evolved, they said that if you go to the cusp overlap view, the chances of putting the valve down, these are minimal, because we know when we put the valve, the part of the valve is definitely in the LVOT. So this is the area from which the left bundle branch travels. So the patients who have the valve that is in the LVOT, more in the LVOT, the chances of blocks are more in such patients. So compared to coplanar view, the patients who have highly calcified valve, the patients, those have calcium in the LVOT. So if you go to the cusp overlap view, the chances of blocks in such patients will be low.
Okay, so again, I want you to pay attention to this picture. The cusp overlap, no, not cusp overlap, yeah, cusp overlap view, which is usually our aortic. Your pigtail sits in the right. This is a bicuspid, so it doesn't matter. So let's just assume the right and the left are fused. It's in the non-coronary cusp, and the right and the left are fused. So see where the nadir of the pigtail is, okay? And look at where we've deployed the valve. We've deployed the valve a good 3 millimeters above, okay? So you understand my point about this is actually a supraannular deployment. Exactly. Not even, this is way supraannular. This is like -2, right? Look at the nadir here, and look at where the valve is deployed. So this is how it looks. Deployment looks great. So I think some of you know this case, so you don't comment, okay? So what should we do at this point? This looks great. We high-five each other and call it a day. It's a Saturday. And by the way, we have another case to do in the afternoon as well. So what should we do at this point? You guys like how the valve is deployed? Yes? Everybody agrees? So we're done. Pull the wire out.
I think always confirm.
You know this case. Don't act smart. You know this case.
I am not according to the case. Just a general point. Always confirm the valve expansion at least in two.
Absolutely.
Two views.
Yeah. So Dr. Kamran has made a very, very important comment here. So this is the cusp overlap. But then when you move to the LAO, you're like, what the hell just happened? So any comments on this? So just pay attention to the calcium here, right? We are done pre-balloon. You guys saw that very nicely. In the previous one, it looks very nicely expanded, but here it's completely constricted. Okay? And what is happening here? This is like an extremely unorthodox view. Why would I get a view of this sort? Have you ever seen a view like this? You're literally looking at the valve so this is a view where you're looking from the apex through the LVOT into the aorta. Okay, so this would be almost, I don't know, RAO, extreme caudal. I don't even remember how we got this. We're just playing with the gantry. So what has happened in this case?
Well, it's very obvious there is a deep indentation.
Yeah, so the valve has enfolded.
Yeah.
The valve has enfolded, and so there's actually a combination of both enfolding and under expansion of the valve. And the problem now is we've pulled out the valve and the wire. Now crossing through this is going to be problematic. So it did take us quite a few minutes to cross through this. But what was reassuring was we knew there was so much calcium that was really going to hold on to this. So then we took the same size balloon again, and I just want you to observe how the valve, the enfolding was gotten rid of. And this should not have happened. Just pay attention. And this is why valves embolize. You see that? See, right towards the end, the last beat, the balloon is 80% still inflated. Either the patient got a PVC or something happened. So the maneuver really is when you inflate this, the primary operator should have a gentle forward tension which I think I did, but they were probably a PVC. If there was no calcium, I could guarantee you this valve would have embolized. And you can see we took multiple views. I think this patient did fine. Actually, on the table, his EF improved to like 45% because the LV was not dilated.
At the end of deflation, you have to pull the balloon, just some traction to the balloon toward. While inflation, you have to give some tension toward the LV, and during deflation, you have to just pull it backward. The technique you are saying.
No. You have to have gentle forward tension on the balloon.
You have to push it,
Because the problem is the LV has now recovered and it spits out the balloon, right? It spits the balloon out because this LV, even with its dysfunction, it's able to mount pressures of 300. Okay, that is something you have to understand. 300 millimeter mercury is a lot of pressure. How hard do you have to push on the blood pressure, if you guys ever used a manual blood pressure, to generate a blood pressure of 300? It requires a lot of effort. So this LV can really spit out anything. All right, so you have to be careful. So let's just say, I hope this never happens, but if we do lots, it'll happen. Let's just say the valve is now embolized.
If the valve has embolized from its annular plane,
what's the first thing you're going to do? You're going to blame your secondary operator, okay? You'll tell him it's your fault. So that's the first thing you do. Get the monkey off your back, okay?
Most of the time, actually, is the mistake of the second operator.
Yes, there you go. Okay.
So if the valve has embolized, definitely we have to order to prepare another valve of the same size.
Okay.
So the most important thing is that we should try to keep the valve just around the root. It should not be embolized to the arch of the aorta, where it can obstruct the great neck vessels.
Mm-hmm.
So we should try our best to, in a sense, we should deploy the other valve, and we should jail the first valve. It should
okay, all right. So just hold your thought there. So let's just say the valve has embolized, and the distal end of the valve is now at your STJ. What are you going to do? So, and let's just say you're lucky, your wire is still across.
Yeah. So definitely we should try to prepare another valve. No. There's no point in snaring such. You'll go and you'll tear the whole aorta. So we should go for
let's just say the diameter of the aorta is above 4.
Still, if it is, we had a case in our experience. We had a patient in which our valve embolized in the upper part of the in the ascending aorta, just below the neck vessels, and we went and deployed the second valve. But the most important thing is, ideally we should jail. Our first frame should be jailed by the second valve, with the frame of the second valve, in ideal situation. But if still we were not able to jail the first frame, and it is quite high, so we can go with the balloon to
more if a valve is the STJ, because the diastolic filling is so you put another valve, the chances of coronary flow will be.
Okay, you guys understand what Jehangir just said?
It was very slow. I think you have to speak a little louder.
Because mostly the coronary flow occur in the diastolic phase. If a valve is embolized into the aorta, while you put another valve at the position, there's a little diastolic filling in this area. So chances coronary perfusion will affect it in these. You have to check first.
I'm just asking because...
No, let's finish that thought.
No. This is just for the thought which is coming. Maybe it is valid or not. You can just have your experience accordingly. I mean, is it possible if your valve is still in the aorta, you can just bring it or pull it back a bit and then you deploy it somewhere in a decent position?
Where? What's the decent position?
I'm just asking. Is that possible? Because rather than leaving in just free valve, I don't know.
So sometimes if the aorta is
We have seen
dilated,
people
while it
have
still
used-
come
Because
in the arch,
We have seen people have shown some cases, especially in TCT, where they have used that or similar kind of valve in the venous, system just to control the, significant DR or something like that. I don't know.
Sir, I would say that you have to snare this first.
Where to
valve.
snare?
I'm telling, beyond this STJ junction, just above it, and then put another valve so that there should be a space between it, so that the flow to the coronary should not be compromised. That's what I.
Yeah, see, what you have to understand is this. Now, one could argue that yes, if your sinuses are huge, don't worry about it. But understand that when you put a second valve through, the flow now is going not in the sinuses anymore, because the tissue that is sewn to the valve is now covering both your frames, the one that is embolized and the one that is lower down. So you've literally trapped the coronary arteries. You understand? Because there's no flow going around. Yeah. You understand? Because you formed such a tight seal in the supraannular structure. So you have to be very careful. Ideally, you would want to put a snare. Now, the other thing is, if you deploy the valve and the patient goes into incessant VFib, what happened? You deployed the valve and the patient is just going into VFib. You're like, what happened to the patient?
You have to look for the ischemia, the obstruction of the coronary.
Yeah, so a patient is, a life-saving measure really is to snare the valve. That is one very rare instance where you would intentionally snare the valve back. Okay.
Sir, I want to comment here. Can we place? It's a core valve. Can we place another valve with the less advantage, like Edward Sapien valve here?
Dude, if we had Edward Sapien, we would not be using core valve.
No, not here. I'm just asking if you.
Yeah, you're right. You're right. So yes, that's the standard. That is the standard way of doing it. So if you embolize an evolute, you would want to put in a Sapien. Okay.
Again, the problem.
Are there any other points of discussion?
So if continue your if patient develop continuous ventricular fibrillation after the embolization and putting a second valve, snaring is the option. You just snare it out and just give the space to the cusp.
Okay, let's just say that you just can't snare this because you've put a 29 now and you've post-dilated it and it's so hard you broke the snare. What are you going to do now?
Let's try to take a guider and then a guide extension.
The patient's in VFib, dude. You can't do that in your acute MI patients when they're in VFib, let alone. So the first thing, this has happened, in our earlier experience, this happened at least a couple of times. The first thing you do is, so we had mandated, the first few times it happened, we had mandated that we would have ECMO in the room. So you have big sheets, okay, you pull everything out and you just put the patient on ECMO. Patient goes on ECMO, patient lives. Then you can take your time, engage with guides, use the back end of the wire to get rid of that, puncture through that calcified jailed leaflet. You can do like 10 different maneuvers. But the first thing is to put the patient on pump, put the patient on ECMO.
Sir, whenever we are doing such calcified cases and we are taking the perimetry measurement, we should include the calcium inside and should take a oversized valve in these cases?
No, so that's a good question actually. You always would, the border would be outside the calcium. You don't go on the inner aspect of the calcium. Because understand that that calcium is what the valve is going to abut. And so if you have a nodular calcium, there are 2 or 3 issues. The most common that's going to happen is you'll have what? You'll have PVL, okay? That's the most common nidus for paravalvular leak. And then if you get too aggressive with post-dilation or with balloon expandable, which this would be a relative contraindication, you could cause an annular rupture.
Sir, but which size, if our perimetry area is coming between 26 and 29, then which valve size we usually take if there is severe calcification? 20, the bigger one or smaller one?
No, see, the answer is not as straightforward. You have to look at other things too. So if you're just telling me there's nodular calcium and you're in the border zone, if you're in the border zone, the sinuses are generous, STJ is great, you have some LVOT calcium, well, we can deploy the valve 100-0. So I would go with a 29 or 26. So there are multiple things that you have to look at, right? It's just not calcium alone that will help you decide. Any other questions, comments? All right, thank you so very much. And I hope you guys enjoyed this.